Okay, so to continue with the program, it's our great pleasure to invite Jonathan Javitt to address us all on the work of NeuroRx with ketamine and neuropsychiatry. This is an extremely hot space. Jonathan is an adjunct professor at Johns Hopkins University and a graduate of Cornell, Harvard, and Johns Hopkins itself. He's published, I think, over 200 different papers. He's pretty well known. He's been participating with NRX for many years, I think 8 years with us in our conferences. So I think without much ado, I'd just like to hand over to Jonathan. And I think that I'm really glad that beyond the people here attending, that this will be broadcast as well. And so there's wide interest in the work being done here. Thank you very much.
Thank you, Leonard. It's really a pleasure and an honor to be invited to give the keynote this year, and really a pleasure to congratulate you on having organized this conference and consistently identified the next big trends in neuroscience. And I think as you look at the next generation of drugs that will treat the brain and the central nervous system, it'll be accurate to say that you saw it here first. So what I'd like to do today is talk to you about NMDA antagonists in general, but ketamine in specific, as treatments for suicidal depression. When Leonard first invited me to speak to this audience, we had early evidence. We had a number of early academic trials, but 7 years later, we believe that there's compelling evidence in hand, and it's time to go talk to the FDA. Now, because NeuroRx became NRX, a publicly traded company, I'm offering a safe harbor statement saying that everything I'm saying today is true as we know it today, but science always changes, and facts on the ground may change as we go forward. So I think we all know that suicidality, suicide, is a national crisis. The reason Robert Graham Jr. Was instrumental in helping me publish this op-ed in the Washington Post back in 2018 is because both his father, the legendary founding publisher of the Washington Post, and his brother had committed suicide from bipolar depression. And although we recognize that suicide's a national epidemic, we really haven't yet treated it as such. We're beginning to. Congress is recognizing it, the Veterans Administration has recognized it, and now we need medicines. So developing a cure for suicidality has been our mission since 2015. And we've launched an initiative to bring our first drug, NRX-100 or ketamine, to the FDA. And as many of you know, we have an oral chronic use drug, NRX-101, which is a fixed-dose combination of D-cycloserine and lurasidone that we hope will be right behind it. But if approved, this will be the first drug to have a label for treatment of suicidal ideation. And suicide kills far more than 50,000 Americans each year, and it disproportionately affects people who have bipolar disorder. People with bipolar disorder are 10 times more likely to die by suicide. Tragically, if you know 2 people with bipolar disorder, one of them is likely to attempt suicide during his or her lifetime. And if you know 5 people with bipolar disorder, one of them is likely to succeed in ending their life by suicide. So we're talking about a condition that needs a drug. Well, after 20 years of ketamine research, there are key changes that have happened in the ecosystem. So all of this began in 1987 when my younger brother Dan Javitt first discovered the role of the NMDA receptor in the brain, and initially it was a model for psychosis, but in 2000, Rob Berman at Yale discovered that ketamine and other NMDA antagonists were potent antidepressants. So we have compelling evidence now, really evidence that's only amassed in the last 2 years, that ketamine is not only effective, more effective than placebo in treating suicidality and depression, but it turns out to be more effective than electroconvulsive therapy. Surprisingly this year, we saw that nasal ketamine did not succeed in treating symptoms of acute suicidality to a statistically significant level. And yet we've seen a rapid proliferation of ketamine clinics throughout the country that are buying ketamine from compounding pharmacies, in some cases under highly questionable circumstances. So everybody's talking about ketamine, but there's really an urgent need to take it to the FDA to get a proper label under a risk evaluation management strategy, a REMS program, to bring a modern formulation to the market, and a presentation that's meant for single patients in a tamper and diversion resistant manner. So that's why ketamine and why now. And recognize that suicide is an underreported cause of death. Probably many of the people who commit suicide are recorded as having died in vehicular crashes and other things that are not specifically identified as suicide. But when you take a look at death by suicide compared to breast cancer, prostate cancer, vehicular crashes, this is something we need to do something about, and we need to do it today. Because today the only FDA-approved therapy is electroconvulsive therapy, electroshock therapy. And when you talk about electroshock therapy, you're talking about often 2 to 3 sessions a week of general anesthesia and inducing a seizure in the brain. In fact, the main difference between electroshock therapy today and the scene that everybody knows from One Flew Over the Cuckoo's Nest is today patients are anesthetized and paralyzed, so you don't see the effect of the seizure that you're inducing. But it's not too different from hitting Control-Alt-Reset on the brain. Now, IV ketamine is being used off-label, but as long as it's being used off-label, it's not reimbursed by insurers. It's really only available to people who are able to pay out of pocket. And that's hardly what we want for a drug that has the potential to be life-saving. Now, there are 125 drugs on the market, and with the exception of esketamine, they all cause suicide. And that's because, at least in our view, for 70 years, we've been looking at the wrong neurochemical pathway, that serotonin axis that is impacted by all of the SSRI and SNRI antidepressants may be effective in reducing depression, but there's a black box warning saying that these drugs increase the risk of suicide, and they do that because they increase a side effect called akathisia, which can be measured in the laboratory, but when psychiatrists say that they know it when they see it because patients kind of can't stand still and they're pretending to smoke and they can't stay in the chair and they're fidgeting. And those are the people who jump off of balconies and in front of trains. And it's a well-known side effect of all of the serotonin-based drugs. Now, we do know that NMDA antagonist drugs decrease suicidal ideation, but for the first time, we're able to unite psychiatry and neurobiology. So when I talk about NMDA, we're talking about a pathway, a little channel that sits on the surface, the cell membrane of every brain cell, that enables calcium ions to either flow into the cell or not flow into the cell. And what we know is that at high levels of NMDA activity, your thoughts are slowed to a crawl. You don't have too many new thoughts per minute, and you tend to ruminate on those thoughts that you do have. What's changed in a very dramatic way is we're now able to replicate, to correlate the inhibition of that receptor with some striking changes in biology. And this is work that was done out of Cornell, showing that at high levels of NMDA activity, synaptic plasticity, and for those of you who are photographing this, these slides are now on our company's website and you're welcome to use them. High levels of NMDA activity result in a loss of synaptic plasticity. In other words, brain cells stop reaching out and connecting to other brain cells. You see atrophy of the dendrites that cells use to talk to one another. And when you add an NMDA antagonist, when you add ketamine to that laboratory preparation, all of a sudden you see brain cells sprout and forming new connections. Some of the people who run ketamine clinics are advertising that we help you make new synapses. And they're probably actually telling the truth about that. That does seem to be what's happening in the brain. And you can also see striking increased levels of cortical glutamine in humans when you measure this using magnetic resonance spectroscopy and carbon-13 labeling. You can actually see that not only is use of ketamine associated with increased levels of glutamine in the brain, but you can see that those increased levels of glutamine are correlated with profound decrease in depressive ideation as measured on the standard scales that are used to measure depression. So really, for the first time in human history, to the best of my knowledge, we're able to correlate a specific channel intervention in the brain with real-time changes, both in neurobiology and neurochemistry. It's never been shown for any of the serotonin drugs, for instance, but it is shown for the NMDA antagonist drugs. So the first reported observation that ketamine has an effect on suicidality was an open-label, single-center study done at Mount Sinai in 2009, showing that as you gave ketamine to people with significant levels of suicidal ideation, that suicidal ideation dropped quite substantially, p-value of 0.001. Yes, it's an open-label trial, and yes, it required confirmation in randomized prospective multicenter trials, but it's these open-label hypothesis-generating studies that lead us to new science. And this was followed by a seminal trial conducted by Professor Mauricio Fava at Harvard Mass General, where they did a dose-ranging study with different doses of intravenous ketamine in order to establish the right intravenous threshold for reducing depressive ideation. They weren't able to do a trial like this with actively suicidal patients, but they did this with patients who had severe depression. And you can see that the 0.5 milligram per kilogram dose was the one that was shown to be optimal for treating these patients. So with that in hand, 2 well-controlled trials were performed. One of them, a study done in 7 French hospitals, funded by the government of France, 156 patients. And you can see a profound reduction in suicidality as well as depression in patients who got 2 IV infusions of ketamine. And if you go and read the paper in the British Medical Journal, you'll see that patients who had bipolar depression had far more efficacy, a far greater effect than people who had other forms of depression. A nearly identical trial was done by Dr. Grunbaum and Mann and others at Columbia University. In the case of the French study, they did a trial against placebo. In the case of the Columbia study, they did a randomized trial against midazolam so that it would be an active comparator, because patients are expecting to feel something, and if they don't feel anything, they might think they got the placebo and give you different answers. So this was done against midazolam as an active comparator. And you can see that by day 1 post-infusion, there was a profound difference between the people who were randomized to ketamine. That's the red line. You can see that their scores of suicidal ideation dropped far more than the people randomized to midazolam. That's the blue line. So then they took the people who were randomized to midazolam and gave them ketamine. That was open label, but they gave them ketamine, and lo and behold, their suicidality scores dropped to match the people who had gotten ketamine in the first place. So 2 well-controlled, randomized trials, one in France, one in the United States, multiple sites, good study monitoring, and that really confirms in many ways the hypothesis that was shown in multiple single center, smaller trials. Where it got really surprising to us is when ketamine was randomized against electroconvulsive therapy, against electroshock. Now, there's not really a good way to do this as a double-blind trial, because you would have to anesthetize the people who were going to get ketamine and give sham infusions to the people who are going to get ECT, and IRB is not going to allow that, even though clinical trials purists might say it's a good idea. So it's an open label randomized trial. The objective was to show that that ketamine was non-inferior to ketamine, but in fact, the effect from ketamine was larger than the effect from electroshock therapy, ECT, as measured both on the suicidality scales, as measured on the depression scales. Now, clinical trials purists would say, well, all you've proven is non-inferiority because that's what you set out to prove. But in fact, if you do a post hoc analysis, you'll see that ketamine was superior. More importantly, ketamine didn't have the safety findings. It doesn't cause memory loss. It doesn't cause personality changes the way electroshock therapy does. So from a patient's perspective, this might well be a preferable treatment. But the problem is, despite clear benefits, ketamine has clear risks. Ketamine is a neurotoxic drug. It kills brain cells. The FDA itself has published data in primates showing that chronic use of ketamine, repeated use of ketamine, can quite likely be harmful to the human brain. Ketamine is known to be an addictive drug. And in fact, there are people who have serious problems with ketamine addiction because they've abused ketamine for its recreational purposes. Ketamine causes hallucinations, which is why some people like to abuse it. It can also cause acute hypertension, acute rises in blood pressure, which are fine and easily managed in a carefully controlled clinic environment, because we've got plenty of drugs that will reverse that. But if you were to mail order ketamine to people, as has been tried and as the FDA has warned against, that could be very dangerous. Ketamine also has the potential to cause vomiting. And if you have an uncontrolled airway and aspirate, that can be a lethal complication. And as we learned the hard way a couple of weeks ago with Matthew Perry, if you're in a hot tub and you take a large dose of ketamine, you may drown. So this is not a drug to be taken lightly, and it's probably not a drug to be used on a long-term basis, but as a drug that can be used to immediately reverse acute suicidality. There's now an extraordinary amount of evidence in hand that ketamine may be extraordinarily effective if you take into account the risks. And that's what's caused Professor Sanjay Mathew, chair at Baylor, to say in JAMA Psychiatry, well, if you're choosing between ketamine and electroconvulsive therapy, ketamine may actually be the better treatment. And similarly, what caused Drs. Wilkinson and Palomar and Dr. Sanakora, who's one of the pioneers in the use of ketamine at Yale University, to point out that we're really at a moment where we're seeing a treatment shift happen in front of our eyes. But it has to be done in a carefully controlled and safe manner. There's an urgent need for an approved form of intravenous ketamine. The FDA has issued 2 recent warning letters to compounding pharmacies and physicians saying this is not a drug that should just be ordered from a compounding pharmacy. And the FDA will probably step up its warnings, and both FDA and DEA may focus on enforcement action because this is a Schedule III dangerous drug, and if used in an uncontrolled manner, can have dire consequences. So although we believe that ketamine has enormous potential to be a life-saving drug, and we've said to the public that we're approaching FDA for a label on ketamine because that will give improved patient access, but also improved patient safety and improved compliance with the law, especially around physician training and preventing this drug from being used in an irresponsible and diverted manner. And that's why NRX has established a subsidiary, Hope Therapeutics, that will be bringing ketamine to the FDA this year and hopefully to the public, both in the United States and in partnership with Fondation Fondamentale in Paris in Europe. So thank you so much for inviting me today. Leonard, thank you for organizing this extraordinary conference, and I wish you all the best.
Thank you.